Hello, and welcome to the Postpartum Years podcast. I'm your host, Dr. Ellen Kramp. I am a physical therapist and a pelvic health specialist. Today, we are going to be discussing tongue ties. And with me today, I have my partner in crime, Catherine Halek. Cat is an IBCLC extraordinaire. She is one of those super gifted people at what she does. And I know tongue ties aren't so much postpartum, except for the fact that they affect mom so much. So that's why we're discussing this particular topic in a postpartum podcast.
Mhm.
So, Kat, why don't you tell us what a tongue tie is? Because first we're going to start with an anterior tongue tie.
So, an anterior tongue tie in the mouth and in the body, we have frenulums. And frenulums are connective tissues made up of fascia. And so there's frenulums throughout the body. There's also frenulums in the mouth. And there's multiple frenulums in the mouth. But the main culprit for a lot of feeding issues with infants is the anterior tongue tie. And so basically, it's just the connective tissue underneath the tongue that tethers the tongue to the base of the mouth. So everybody just simply having a baby open their mouth or having an adult open their mouth and seeing connective tissue and seeing a frenulum does not mean there is a tongue tie happening. It just means that we all have frenulums. They exist. We all have them in multiple places in our mouth and in other places in the body. When we think of anterior and posterior, I want you to think anterior is towards the outside of the body or to the front, and then posterior is towards the center of the body or to the back. So an anterior tongue tie is where that connective tissue is connected oftentimes to the tip of the tongue, and it affects the way that the tongue's able to move.
Yeah, we've got a picture here of a baby with a definite anterior tongue tie. And you can tell, even with this baby crying, you can see the strain in
Yes.
that frenulum. So, that little piece of connective tissue attaching the tongue to the floor of the mouth is really tight and not allowing that baby's tongue to
Yeah.
elevate.
I'm just recognizing which baby this is that we've worked with, Marielle. And I was like, oh, I know that baby.
Yes, you do. You know
Um,
this
I
baby.
also just want to point out, with this baby, crying and the mouth is open. If you look at the upper lip, there is like blisters, like they're like little compression blisters. And that also can be a part of the picture for like oral dysfunction with feeding, is that you'll see compression blisters. And having some compression blisters at the very like the first week of feeding, yeah, that's within the realm of normal. Just, baby's trying to figure out how to use its mouth. It happens. But this was chronic and reoccurring. Like those marks on this baby's upper lip were constant. Like it wasn't going to go away unless something was done about that tongue.
In the next picture, I see teeth in this one.
Yeah, this is an older kid.
And this is an older kid, and you can see the tip of the tongue there is tied down to the floor of the mouth, and that's abnormal. That
Yes.
that should not
Yeah.
be happening.
Yeah. That's a frenulum, and everybody has frenulums, but that's an abnormal frenulum.
That one is abnormal. You
Yeah.
you should not see the tip of the tongue um, directly connected to the floor of the mouth.
What's interesting in this picture, Mary Ellen, is how if you see the front two teeth are kind of curved inwards. So it's affecting the way that the teeth are growing in also.
Yeah. And I just wonder, as a baby, how was this poor kid feeding?
Eating.
Yeah.
Yeah.
And speech, I wonder what sort of speech issues this child may have, since they can't get the tongue to the roof of the mouth.
Yeah. And honestly, with how that's presenting, I'm wondering if it also could move side to side or lateralize well,
Hmm.
which oftentimes anterior tongue ties, like the tongue can't move, especially with breastfeeding. Specifically with breastfeeding, they're supposed to have this wave motion, like this peristalsis wave. And if the tip is tethered, it doesn't do it.
Right, right. And usually these kids are the ones that are chewing at the breast
Oh,
rather
with
than
their
sucking.
gums.
Yeah.
Yeah. Oh,
So the poor nipples tend to get really beaten up.
yeah. I've had some pinky gnawed on by many babies that were tongue tied anteriorly.
Yeah. And this next picture that we have is another picture of a tongue tie. And we have a before and after. So this is at a pediatric dentist's office, and the dentist was assessing how tight this particular tie was. So
Yeah.
here's the before picture. You can see that really tight connective tissue between the dentist's gloved fingers, and you can see, just with him trying to get his fingers in there, that floor of the mouth being lifted up because that tie is so tight.
So this baby, I got permission to use these pictures from the mom, and she's also a pelvic floor therapist in Florida. And the this presentation, this style, we call it an Eiffel Tower presentation because it looks like the Eiffel Tower. And then also, what an interesting thing about this baby also had torticollis. And so this picture, even though it's kind of like the angle's a little funky, you can kind of see that on the right side, like left when we're looking at it, but it's the baby's right side, that there is a little bit more blanching at the base than the left side. Well, the baby was tighter on the right side than the left side. And this mom said, and I think the baby was 3 or 4 months when it got released. When the frenulum got released, the baby had better range of motion and stopped, and the torticollis resolved itself like within days.
Cool. This is immediately after that frenulum, that piece of connective tissue had been cut. And the interesting thing is with these dentists that are using the lasers, we've observed these, and I was shocked at how the baby would scream during the exam, but then be perfectly fine when the dentist was using the laser and cutting this tissue. It was absolutely phenomenal to watch that, you know, cutting the tissue, the baby had no reaction whatsoever, but don't examine that baby because baby wanted nothing to do with just the exam.
Yeah,
But
well, with the
afterwards,
exam, they're fighting something that is stuck. So like you have a crick in your neck. And so it's like if somebody's trying to like get your neck to move in the way it doesn't want to, because it wants to stay like this, and you're trying to push it to move it, it's going to freaking hurt and it's not going to be comfortable. And also, who likes somebody poking around in their mouth and just like lifting things and pulling things and poking things? I'm not a fan if you just went in there, didn't buy me candy or flowers or take me out to dinner and just went in there and just started jabbing. I wouldn't be a fan of that. And I feel like babies are kind of the same way. They're like, what the hell is going on? This is not food. And you're under my tongue, so I can't even suck. This sucks and not in a good way. So
yeah, but I still would have thought that having the tissue cut,
yeah,
even by a laser, would
yeah.
would be the most painful part, and it wasn't.
Nope. I don't I've seen, so like I've seen three, no, I've seen four different pediatric dentists, sometimes up to three releases I've witnessed. And almost every single time it's what you described. Now, afterwards, the tissues do swell, like the base of the tongue will be swollen, moving the tongue will be uncomfortable, and babies experience varying levels of pain and discomfort during the recovery process.
Mhm. Moving on, lip ties. This was another one that we see and can be problematic for kids trying to latch on, particularly to the breast.
So, in the lactation field and in the tethered oral tissue field, uh, or TOTS field, there is some controversy about lip ties because it is within the realm of normal to have a frenulum in the lip that connects pretty far down the gum ridge. It's when we see like the lip is not able to move, it's super severe. You've taught me how to do some exercises with lips to free them up so I can really get like a more accurate read on whether or not it's a true lip tie or not, or if it's just tightness. But when I see a frenulum almost like to the fulcrum of the lip and then also to the gum ridge, and then sometimes it's kind of like a knot and it's behind the gum ridge too,
Hmm. Yeah.
and that lip can't budge, then I'm just like, yes, you can be controversial all you want. That's a freaking lip tie. They do exist. I think that they're overdiagnosed and overly released, but they do exist in my clinical experience.
Yeah, I've seen it where the baby just, the lip just cannot move. They're tucking the lip under the gum
Mhm.
when they're trying to feed.
Yep,
Often
they
they end
can't
up
flange it.
chewing. Yeah, they can't flange it. And the tucked lip, I mean, think about trying to suck with your lip tucked under. That
Yeah,
throws the mechanics of everything off.
yeah. Lip flanging is important, especially with breastfeeding. And honestly, a lot of these babies, we see the signs of the lip and tongue tie, but I've seen exclusively bottle fed babies struggle to bottle feed and maintain suction on a bottle nipple, and a bottle nipple is consistent, like it's the same every time as long as people are feeding the same with the same bottle with the same flow nipple. Sometimes people jump around and that causes issues with feeding. But the breast, like every time you go to the breast, it could be just slightly different. It could be fuller, it could be emptier, it could be tighter, it could be looser. The nipple could be a different temperature, the flow could be different. And so, not being able to flange your lips and create a good seal on the breast causes a ton of feeding issues. And anterior tongue ties and lip ties both cause those issues.
Yeah. For reference, I've got a picture of a lip tie in an adult because I happen to know this adult who was getting this release done. Um, he was noticing that his teeth were separated and it just seemed to be getting worse and worse on him. And so his dentist was going ahead and doing this lip tie release on him because he had previously had braces and things just weren't holding stable for him anymore. What I have seen with some adults with particularly with the big gap in the front teeth is that frenulum comes all the way down and like you had described sometimes um, comes all the way around. Some of them it holds their lip up so high
Mhm.
that you're looking at all of their teeth almost all of the time.
Yeah. And they can't even close their mouth sometimes.
Right.
There's this one family um that I knew. The whole family had lip ties. Like
Look like they're smiling all the time.
it was almost like the lower lip had to go up to the upper lip instead of it meeting.
Right.
It was interesting, yeah. And I back then I didn't know what was going on, but looking back I'm like, well, they all had lip ties.
Yeah.
The whole family.
All right, so this is the before picture, and then the next one is immediately after it was
Mhm.
released. And then we have a third picture, which was just, I don't even know if it was a full week later, but how quickly that heals up. Now we're going to move on to what signs and symptoms that a baby might have.
I think the most overt one that really, gets me like a red flags is that nipple and breast pain. And sometimes it can cause reoccurring mastitis, clogged ducts. I've also seen a higher incidence of reoccurring yeast or thrush with babies that have oral ties. And I don't really know why, but I've just seen that clinically. Noisy feeders. There's a series called How I Met Your Mother, and in this series, there's an episode where they all kind of like point out each other's annoying habits to each other, and it's like, and they make this sound like with like the glass shattering, like oh crap, that person talks way too much, right? And so I hate being this person, but so many times somebody's coming to me for feeding problems, and I'm just like, that's not normal. What's not normal? That sound. What sound? Baby's making a sound while they're eating? And I'm like, yeah, that's sound. And it's systemic. It's like a clicking noise or a slurping noise or just a lot of different, and I'm like, yeah, babies aren't supposed to be that loud when they're feeding. And it's like I can see like the expression on people's faces, and it's like the glass breaks, and they're like, and then they can't unsee it. And then, unfortunately, which I don't like being the cause of this, they also hyper focus on it. I'm like, no, 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 no. Like the baby's alive, everything's gonna be okay, but we'll be doing better when that gets better. And I think it's the same thing, Mary Ellen, for me after working with you with like torticollis or like facial or body asymmetry. It's like I point that out, or tension in the body in certain places. I'll point that out to a family. It's like the glass is breaking, and they're like, I can't unsee it. But they were like, it was fine. I didn't even know it was a problem. So I just think that that's an interesting part of what I do for a living, is I get to break some glasses and make people see things, which I don't love, because then oftentimes they do hyperfixate on it
Hmm.
because they're like, "Oh, this is the cause of my problems." Hyperfixate. I'm like, "Yes, and like take a chill pill." So some babies are simply incapable of a deep latch when they have tethered oral tissues in their mouth. And so, parents, moms often come to me, well, I'm working so hard for this deep latch. What am I doing wrong? And I'll watch and watch and watch and watch. And sometimes it will look really good from the outside first. And then the baby will like start to drift to the tip of the nipple. So like they'll get a good latch initially, but then they can't maintain it. Or sometimes they're incapable of getting a good latch. It's just not possible because of the anatomy. You're not doing anything wrong. It's a problem with this anatomy, and it's not your fault that this is a problem. So I like that part of my job. A telltale sign is when you work repeatedly on getting a deep latch, and maybe they'll be able to maintain a deep latch for like 10 seconds. And then as they're eating or as there's flow, they drift to the tip of the nipple. I also see this, I see like a pattern with this clinically for years, that in the hospital or right after birth, when the breast is only producing colostrum and is not swollen or engorged at all, breastfeeding's fine. Or they're compensating. It might not be the best, maybe it's a little tender, a little sore, but it's not that bad. And then the milk flow comes, and then or engorgement happens, or the increase in flow, and the baby goes straight to that tip of the nipple and is just gnawing away and causing damage and pain for the mom and lots of different issues. And that shallow latch and an ineffective latch can also cause mom's milk supply to plummet.
Because the
So
baby just isn't getting enough.
yeah.
It's painful for mom. She doesn't want to sit there
Yep.
while she's in a lot of pain, because
Yep.
that shallow latch, that drift toward the nipple is painful, and that's a lot of times why moms end up seeing us,
Yep.
because of that pain.
Yep. The popping on and off the breast and bottle, again, it's the combination of like maybe the baby can latch, create a seal on the breast or the bottle, but then flow happens, and then they have to suck, swallow, breathe, and they're like, ah, and they can't handle it. And so it deteriorates. Milk dribbling, a very telltale sign of lip or a tongue tie happening, is when the baby takes a bottle and the milk just dribbles out the corners of the mouth down the cheeks. Like I've seen that so many times. And mind you, there's ways to compensate temporarily, different positions, slowing the flow, holding in different positions, trying to figure out how to modify that. But if that's oftentimes I'll be doing that and it's still an issue. And those babies that are doing that milk dribbling and all that stuff, and it's still an issue, it's still an issue, it's still an issue. I often see those babies are the ones that have weight gain issues, because like even with the bottle, there's weight gain issues. And
Mhm.
What's interesting, Marielle, and I don't know if I've ever told you this. I was working with a family, and the mom was breastfeeding, and she was using a nipple shield. From looking down, the latch looked freaking amazing. Amazing. It looked like a beautiful latch. But I was curious because I saw milk kind of like dribble down mom's side. And I was like, that ain't right. Why is there like, I was like, does that always happen? And she's like, yeah, my lap's always wet after I breastfeed. And I'm like, so I took a camera, I took my phone and like recorded underneath the latch, like underneath the latch to see what was going on that I couldn't see. And the baby had like beautiful open mouth on one side, not open mouth, and it was just dripping, drip, 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 like just falling out of the baby's mouth on the other side. And I was like, "Oh no." And that baby had a lip and a tongue tie, both.
I put together some slides for the nerds. So, for those of us, people like me in particular, that want numbers, um, I found studies that showed complaint prevalence. So, 81% of women reported poor latching. 73% of them reported that the baby fell asleep while attempting to nurse.
So another clinical, consistent symptom that I see with infants that have lip and tongue ties is that they are snackers and that they fatigue at the breast. So they can only eat actively for so long without getting really, really tired. And they only eat enough to survive, not to thrive. And they want to eat very frequently, or they either want to eat very frequently or they just never want to come off the breast and they are never satisfied because they're not actually transferring effectively.
Yep, see that with so many babies, so many
Hmm.
babies. Creased, flattened, blanched nipples after nursing was 68%. So blanched can be either a vasospasm, so some tension in an artery that's not allowing enough blood flow, or it can be the way that the baby's latching and cutting off some blood supply because these kids are chewing the nipple. They are not usually sucking the way that they need to. And again, gumming, chewing, 67%, and that goes right along with the previous complaint.
Shallow latching, which sometimes is just a shallow latch and sometimes is a symptom of, lip and tongue ties, will also create like dried skin at like a compression stripe where like some of it is the blood flow is cut off and some of it is that it's literally like chafing the nipple to where there's just like a ridge of like skin that develops or like or sometimes even blisters, which is just oof,
Yeah, and I think
gnarly.
that trauma to the nipple is probably why you see more incidents of yeast infections
Yeah.
because you have breakage,
Yes.
and that's just a way for infections to be happening. And then it's a dark, warm environment, and yada yada
Yeah.
yada, and there you have your recipe for yeast infection.
There also with nipple breakdown and nipple damage there is an incidence of bacteria and it's like the mastitis is coming through that like
Right.
and oftentimes when I see that the mastitis that I'm seeing is not inflammatory, it's
It's
actually
infectious. Hmm.
bacterial and it needs
Yeah.
antibiotics.
Yeah. More, more, more numbers for the nerds.
Statistics.
Yay. Um, there can be poor or incomplete breast drainage, and that's about 60% of people. Um, Sliding off the nipple when attempting to latch again and again and again. That's another 60%. There can be severe pain when the infant attempts to latch. And again, that's close to 60%. We're back to cracked, bruised, blistered nipples, sometimes even reflux
Hmm.
symptoms, just because of the dysfunction with
Yeah.
suck, swallow, breathe.
There's a lot that goes on that and you and I, we've worked with Barbara Nelson, a speech language pathologist that specializes in infant feeding. And I feel like through our work with her, we understand like how one little thing getting thrown off can really throw off the coordination of this very intricate process that is suck swallow breathe. Reflux symptoms, on the previous slide, I believe that we also had gassiness.
Hmm.
So babies, when they're not creating a seal well, when they on the bottle or breast, when they're making those slurping or those clicking noises, they actually are swallowing air, and they'll gulp air. And so that those air bubbles, the gas will cause, they'll be gassier, they'll be fussier. And then also sometimes gas and reflux travels together. And it's like the gas bubbles and the squirming and the dysfunction and like, and then, an air bubble comes up, but it's juicy. It's not like
Hmm.
a dry burp. It's a juicy burp, and like stuff is coming back up. And if that's keeps on happening and the esophagus is getting irritated, then it kind of is like a feedback loop that just keeps happening. And especially if they continue to eat with that dysfunction. And yeah.
This is another one last thing on that side was like 40% of kids are not able to hold a pacifier
Yep.
in their mouth.
That's actually a diagnostic tool that I use. And sometimes they'll only be able to hold a certain type of pacifier in the mouth. And it's usually the ones where it's like the orthodontic or the flat ones, or the ones that are, or they can, where they basically are gumming it, they're not sucking it.
Moving on with more stats.
More
All right.
stats. Boop, boop.
And again, this is another huge one that we see. Sometimes the reason why kids are coming to see us is they're not gaining weight.
Yeah.
So about a third of them aren't gaining weight. About a
Yeah.
quarter of them may have colic symptoms, which may go along with tongue tie, but may go along with other things as well.
Yes.
Mom might have bleeding nipples, again, plugged ducts. We see that
Hmm.
a lot. Actually, anytime a mom is coming to me with plugged ducts, I will tell her to bring the baby along to the evaluation
Hmm.
because it's near 100% of the time that
Yep.
there's that latch with the baby is not quite right. Not 100%, but pretty darn close to 100%.
Yeah. Close enough to just bring the baby.
Yeah, just bring the baby.
Just
If
bring
you're
the baby.
coming,
Let's figure
yeah,
this out.
yeah. If you're coming, unless you are exclusively pumping and have a plug duct, bring the baby.
And if you're
Um,
exclusively pumping, bring the pump if you're coming to see me, please.
yes, yes. I always refer back to um, the IBCLC to assess those pumps to make sure it's the right flange, to make sure it's the right settings, because so many times it's not.
Yep.
And that's where some of the mastitis and plug ducts are coming from. With the tongue tie or lip tie, mom might have mastitis or thrush, and sometimes infected nipples or breasts, which we already went over, but that's 14% mastitis and 6% on breast. Let's talk about the effects of tongue lip tie on feeding. So, explain the difference between breast and bottle.
So when babies are breastfeeding, they use more of the muscles posteriorly. So they use like more like the masseter and like the jaw back here. And they kind of have like this like rocking motion where like the upper lip is going to like stabilize, and then the jaw is going to go like this. And inside the tongue's kind of cupping the nipple and doing this like wave motion, right? With bottle feeding, they use their lips more. They use their lips more, and they use their gums more, honestly. And there is still some tongue cupping, the nipple cupping. There is a little bit of some wave happening, but there is not it's not the same. And there's different nerves and there's different muscles at work. And so I wind up explaining this a ton in the hospital, because at the first sign of trouble, early postpartum, you're exhausted, you haven't slept in over 24 hours, you haven't, you're hungry, and the baby is struggling and you're struggling, and people are like, well, what's the harm in giving a pacifier or a bottle? And I have to explain to them, well, part of the harm is that anteriorly, if the baby's, using the front of its mouth and it gets used to that, it's going to keep wanting to do that. And when it comes to the breast, it's going to want to do that to your breast. And it's not going to be able to latch as deeply. It's not going to be able to express and all that stuff. And so, I'm constantly saying, like, when babies bottle feed, they use the front of the mouth. When babies breastfeed, they use the back of the mouth. And Mary Ellen, you gave me a great example after doing some body work on me, some myofascial release. I think I was like saying, like why does it feel so good and I feel amazing right after you're done, but then like within like 24 hours sometimes it's right back to where it was. And you were explaining how, like, what fires together wires together. Think about it, when you're going someplace in the car that you've gone 1,000 times, like maybe to and from your job. Okay, you move into this lane and you stay in that lane until you see, this store, and then you move into the lane that you're about to turn left or right, because you know that you're about to do that, and you kind of just do it, and it's like on autopilot. You're not really thinking about it, you're not really planning. It's just something you do the same way every single time. And so that's the same thing, that when the body has movements, that's what basically Hebs means. It means like, well, if you keep doing something the same way every time together, it's going to want to keep doing that. And so even after you get body work or a massage, your body goes, nope, I remember that you wanted to be cricked like this. So, like, go back. That's what we've been doing for the past month. Go back to do that. It's fine. And so that when babies are feeding, and mind you, like, the main job of a baby is to suck and to feed, like right after birth. Like that's survival, right? They're born to suck and they're born to eat. And so if they start bottle feeding and then we try to get them to the breast, they're like, they're not changing lanes at the right time. They don't know when to put their turn signal on and make that turn, because it's completely different.
Yeah, and that's another reason why I like getting babies earlier rather than later.
For sure.
Getting a baby that's a couple days old or just a couple weeks old when they're still learning that whole pattern of how they're going to eat. Every single feed reinforces a bad behavior if the tongue is tied down, if the lip is tied down. And so to try to get them to learn a new pattern
Yes.
when they're 4, 5, 6 months old after having a tongue tie release, it's much more difficult than when they're 4 days old or 4 weeks old.
Yeah.
So it's very, very different. So yeah, having them early, and while their wires are getting laid down and they're
Yes.
learning how to get from point A to point B, that's the optimal time to get that
For
stuff
sure.
done so they can use the reflexes in their body,
Hmm.
which are wired in to use those movements rather than how to compensate around that.
And during COVID, I was like listening in on a science lesson for my daughter Jax, and I got really pissed off because I don't remember like what part of the lesson it was, but it's just like she was trying to say, like, babies are born to suck, and she said, but babies are born to suck at bottles, and I was like, no, 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 no. Eating a bottle is not a developmental milestone. Eating at the breast is, like, that's the physiological biological norm. And you know how wonderfully intelligent, sweet, and cute my daughter is. And this is like 5 years ago when she was 10. When we got off the call, she looked at me, she's like, Mom, I saw your face change. Like, did that upset you, what she said? Did she say something incorrect? And I said, yes. Like, no, it's physiological normal to breastfeed. Bottle feeding is like a replacement for that. It's a compensation. So babies are born to breastfeed and suck at the breast, not at the bottle. And my cutie pie was like, do you want me to message her? Because I hate when people give out incorrect information. um, Also, a part of this diagram, the breast, there's a lot more going on. The bottle, like I said earlier, is consistent. It's the same. Um, maternal pain is happening. Much the breast is changing, it's evolving. Sometimes it's emptier, sometimes it's heavier, sometimes it's more swollen, sometimes it's less swollen, sometimes the nipple's more erect, sometimes the nipple's less erect. All of those things. And I think it's really also important with breastfeeding to understand for people that aren't familiar with it is the length of feed should be variable. It's not the same all the freaking time. Like sometimes babies, like closer to like 2 or 3 months, they will get into like a really predictable pattern of feeding where, like, maybe daytime feeds, they're super consistent and it's always about 10 to 15 minutes. And then, like, maybe before a nap or maybe before sleep, maybe that feeds like 45 minutes or an hour. But it's really normal, especially in the early stages of feeding, for it to be variable, for it to be all over the place, for it to be 5 minutes to 45 minutes. And then with the bottle, usually like the volume's pretty consistent, And so I feel like, like, and you gradually go up on the volume. So usually the bottle is the same length of the feed. And then it's also very similar.
Yeah, but some parents have difficulty with the baby falling asleep and not staying awake to take that bottle.
Yes.
Others, because the baby's dribbling so much or having such a hard time latching, that it's
Yep.
taking them an hour to get 2 ounces
Yes.
in.
Yeah. And so just so you know, a normal feed at the bottle, like, is 20 minutes or less. And when I'm working with medically fragile infants or with babies that have lip or tongue ties or have other, feeding issues, sometimes cleft palate, things that are going to make it a little bit more challenging, the max a feed should take is 30 minutes. And that's with burp breaks. That's not like, so that's like maybe like closer to 20 minutes of active feeding and maybe even less, and then like padding, burp breaks, movements, changing positions, all of those things, like 30 minutes.
Yeah.
That's normal. If it's past that, that's not normal.
Whether the baby's fed at the breast or the bottle, they may be having issues with being gassy, with reflux, with poor weight gain,
Yes.
and with dribbling, whether they're breast or
Yes.
bottle fed. Now let's talk about the prevalence and the controversy behind tongue tie, because you have two different camps. You have one camp where there's a ton of kids with tongue and lip tie, they all need surgery. And then the other camp was nobody has tongue and lip ties, and none of it needs to be released. And
It's super, or there's like there's like a spectrum where it's like it's super rare and only the worst of the worst. Like if the baby's like about to die, should we intervene with surgery?
and by surgery, it's how many seconds? Like you could easily hold your breath for the entire procedure
Yeah.
without like working to take a deep breath ahead of time.
Yeah. I think that my clients that have had the or tongue tie releases, they're like, why does it cost so much for something that's so fast? Like oftentimes pediatric dentists will have them like leave the room or go step outside so they don't hear their baby crying, and also so that they can do their freaking job without co-managing the emotions of the parents, because so it used to be that they would allow people in there. Now they really don't. I've actually had, like, most of the times that I've observed, it's been because I've referred a patient to the dentist, and they wanted somebody in there with their baby, and they trusted me and felt comfortable with me, and they just met the dentist and didn't,
Hmm.
they
Right.
wanted, they were like, it's okay, like if she's in there it's going to be okay, kind of a thing. Whether, I mean, like I'm going to do something, I'm just there. But they just wanted me there to help them through that process, and so that's when I've gotten to observe most of the time.
Yeah. It was funny looking through different research studies, though. It was anywhere between 4 and 20%
Yep.
of kids who were diagnosed as tongue or lip ties based
Yeah.
on whatever type of exam was used. So,
So I want to unpack that a little bit. Like currently, the hot topic is autism because of our current government. And they're like, why are all these kids being diagnosed with autism? And it's because we broadened our understanding of what autism is, and we changed the definition and we changed the diagnostic criteria, right? So I feel like, when we're looking at these 4% statistics, we're thinking of the worst of the worst anterior tongue ties and only that and nothing else, right? That's what, is there. Also, I have worked with a lot of pediatricians or pediatric allergists or pediatric cancer specialists. I've had a lot of patients that have been pediatrician with some sort of specialty, right? They learned this much about infant feeding. They learned that breastfeeding and breast milk is amazing and really good, and that everybody should do it. And they learned a little bit about the anatomy and the physiology of breasts and breast milk. Like maybe a 2-hour class. Maybe if they were lucky, right? So, and pediatricians, there I also have asked them many times, what is like why do you only care about the weight? And they're like, well, as long as the baby's gaining weight, other stuff can figure itself out in time, or we have time to figure stuff out, right? So they're heavily trained in monitoring weight gain and growth. Not so much infant development, not so much nutrition, and definitely not breastfeeding if they haven't sought extra training. And that's not, they have their job and they have a lot that they have to do to make sure that babies are, alive and growing and thriving, right? It's not a dig at them. That's their focus. If the baby's gaining weight, we have time. And I kind of agree with them. Like when I have a family that I see a lip or tongue tie, Mary Ellen, and the baby's gaining weight, I'm like, well, we can try different things to see if we can resolve the feeding dysfunction before we go to cutting it because the baby's gaining weight. And if the baby's not gaining weight, I'm like, okay, we need to do something faster. So I kind of I get their point, but I would say in my experience, I see a higher incidence of lip and tongue ties because I see a higher incidence of feeding problems. Are times that people come to me and everything's going great, but I would say that's about like 5% of my clients. Like if somebody's reaching out, especially to me in private practice, if somebody's reaching
Hmm.
out or outpatient at the hospital, if somebody's reaching out, it's because there's a freaking problem. They're not coming just to say, hey, can we just talk and hang out and I can pay you money to say everything's great. And I saw that got even worse during COVID. So the incidence of lip and tongue ties that I was seeing during COVID was like way greater when like people weren't leaving their house unless they absolutely had to. They didn't want to risk having their baby around people. Like I saw even greater incidents of lip and tongue tie because that was the only problems that I was like actually seeing in person. People that were doing okay at home and not bothering to like seek out help. So I feel like lactation consultants, we see more lip and tongue tie because we see more dysfunctional feeding. So we're not, every baby doesn't have a lip and or a tongue tie. It's that we see more problems. So we're going to see more than what's out there in the population. It's going to happen because we're seeing the freaking problems. It's like you as a pelvic floor therapist, like the incidents, what you experience the incidence of, let's say, like diastasis or prolapse, you're going to see more than what's out there because people are coming to you because they're having problems, right?
Yep, definitely,
Yeah.
definitely.
Thank you for joining us as we took our dive into tongue ties and its impact on the postpartum mom. It is going to impact her nipples. It's going to impact mastitis. It's going to impact her mental health as that baby is suffering with feeding. So join us as we continue next week and the week after on parts 2 and 3 of the postpartum years as we dive further into tongue ties.